So we're going to start with the committee presentation on the disease markers. I want to thank Dr. Kuo from Taiwan and Yu Chen is junior researcher. They couldn't be here for the meeting. Pradeep, who is part of that committee, is going to do the presentation. Dr. Tyagi.
Thank you, Dr. Vidlani, and thank you, the organizers of this Congress, for giving us this opportunity. We were tasked with this topic, role of biomarkers, and Dr. Ko was leading this committee, and these are other my team members. I want to thank them for their effort on this work. And this picture that you see, that is not AI generated, and none of thing I will be presenting is AI generated, and but this one could be. This is I downloaded from the Microsoft database picture. It looks really real, but could be AI. But it matches with the bladder, heart-shaped bladder, I show. So these are our tasks. Dr. Kaur split them between the different team members. And so with regard to objective phenotyping, you must have heard all that. I see the heterogeneous disease, and I'm just going to repeat that again. So by the end of it, you will remember some of them when you go back home. So, but these are the tools that we can use, CT, MRI, urine biomarkers, and basically the MAP study has shown there are three main phenotypes: bladder filling pain phenotype, pelvic floor tenderness, as all the morning session talked about, and there is a phenotype that overlaps with vulvodynia. So this phenotype, this seems to be the major that is in the MAP study, and then recently a statement came out from OGS and IUGA recently, and they call it female bladder pelvic pain syndrome. MAP called it differently, bladder filling pain phenotype plus phenotype. So nomenclature, nobody can agree, seems to be on a right, simple nomenclature. But recently they studied it with this phenotype by MRI, putting 350 ml water in, ask the patient to drink 350 ml water and then do MRI, and they try to find a correlate of this phenotype in the brain. But I thought they could have also done bladder MRI and could reveal whether there's a difference in filling rates between different phenotypes. And the reason I want to show is that these funnel clouds that I can see in axial slice of a bladder, I thought the ureter will be looking at the bottom, but when you take an axial slice, they look like a funnel cloud that you see in there. And then the middle picture that you see, bladder actually changes the urine composition. That was studied by taking the urine from kidney and the bladder. I cite that paper below. So that the color of the urine that you actually pee out, that's not how a kidney made it. It's ages in the bladder, and bladder reabsorbs water and other constituents, and the end result that come out. So far the role of the bladder in that composition was sort of ignored, and because that was ignored, we didn't reach the full picture. And this bladder filling phenotype that MAP and OGS are talking about, that relates to the previous discussion also, the bladder capacity. So how does fill rate correlates with bladder capacity? Why Dr. Evans has to do anesthetic bladder capacity, or some of them at least, not Walker, just about every them. So there's a difference. This FBC is functional bladder capacity. That doesn't correlate with systematic bladder capacity, and the reason is the fill rate. But there's more correlation. Dr. Koz sent me this data with the maximum bladder capacity that's done under anesthesia. What anesthesia does is it suppresses the afferent, it numbs the afferents, which are stimulated by ATP. So as you increase the fill rate, and the systematic bladder capacity fill rate is 50 ml per minute. This more fill rate, the ATP has a perfect correlation. ATP increases. ATP stimulates, and that's why your bladder capacity is lower in systematic bladder capacity, but is quietened. Another thing this paper from UK, they found was creatinine. Creatinine has no relation with urine flow rate. We have been taught in the textbooks, we have been following the nephrologist all wrong. There's no correlation, there's no justification for normalizing anything ATP or urine biomarkers released from the bladder by creatinine. You get the wrong answer all the time. So that's the first controversial issue I want to highlight for discussion I welcome your points. And the second is this MAP study you see in the brain MRI. So this was, again, with 350 ml water, drinking, and then do the MRI. You can see there were two cohorts. After 60 minutes, some patient voided 800 ml urine, some patient voided less than 200. So what's the cause? This is after they voided first, they asked them to drink 350 ml water, then they voided all this range. So where is this range coming from? So part of the reason is bladder reabsorption. Patient who is voiding 112 ml or 50 ml urine after 30 minutes or 60 minutes, the absorption rate there is 3 ml per minute. And this reabsorption from the bladder, it explains why Senator Cory Booker don't have to go to the bathroom in 25 hours he's drinking the water constantly, and that fact is not understood by the community, but I wanted to bring that. Senator has stood on the floor for 25 hours. We should, no, okay, we can contest on that. So this, how do you study probability? So we have been lucky in getting a grant on this. We put instead of radionuclide, with other people have done, we put gadolinium into the bladder and then studied its permeability. On your on my left and your right, on your left is non-Hunter IC patient, on your right is a Hunter IC patient. You saw that at the beginning they all have a blue color. I changed it to, instead of black and white, change it to color because the color signal range was not that good. You see the non-Hunter IC patient has a red color, means very high signal, it didn't absorb much. What happens to Hunter IC patient? Immediately it went yellow, much lower signal. The reason is it absorbed. Within 5 minutes, there was a 5-minute delay after we put in the gadolinium and before did the scan, we put right out the scanner and did the scanning. So in a Hunter IC patient, within 5 minutes, we see the difference in the signal. So do we see ureters filling? And if you see, we did the T2-weighted image, you can see the ureter jets clearly, it being different. The color of the ureter change with the gadolinium that we put in. In the bottom in the color, you can see actually urine coming out. And we did the dynamic, because these are dynamic images, we did the signal of the ureter and the lesion, and there was clearly a sign that non-Hunter IC, because of the blood flow and the difference between this, there is a clear difference in absorption, and the urine signal is much more variable in the non-Hunter IC, but the urine, within the 5 minutes, it has reached equilibrium. It's equilibrium with the bladder wall. The signal is hardly any different in a Hunter IC patient. So why does inflammation, does inflammation has a role in this bladder filling phenotype? So this paper recently came out from Nimi et al. In International Journal of Urology. They found that with age, as Dr. Parson was mentioning, everything goes up with age. The inflammation IC, as you age 60, 70, it increases. But in BPS, this phenotype, bladder pain syndrome, is much less pronounced compared to. So what is the reason for that? What happens with age that this patient come to the clinic with this inflammation? I think maybe because of ureter jets, they cannot dampen this impulse that is coming. That's one example. In MRI, you see non-voiding contraction caused by water loading, just by asking the patient to drink water, just as MAP did. The urgency was 6 and higher after water filling. So what we think is with age, the fibrosis and the bladder wall thickness, they are not able to dampen the ureter jet impact on the bladder wall, and that is thing. And then with age, menopause comes in, the Treg, which releases enkephalin and IL-10, that goes down. That could be the reason. And then there's a immune response, Th1-based M2 macrophages. That part is also there. Another thing is that in non-Hunter IC and Hunter IC patient, there's a difference in 93% versus 30% success rate of this cyclosporin. And that matches with the inflammation reports also. So if with cystoscopy, cyclosporin success is so high, I was wondering, why does all the failed trials didn't include cystoscopy? Maybe to increase enrollment, they cut corners to get that. So that what could be the factors we need to discuss? So with the age part, we don't have much of a human data, but I have some Laurie Burder's paper, the staining. There's a decrease in peripheral neurodegeneration, and we have this channel, SCN channel was changed. Actually, bladder started expressing the channel that is there in the ureter, which is SCN3. So we found that in the rat bladder, but these two data is animal, others are all human. So to summarize for this phenotype was, the phenotype hinges on inflammation. What happens is inflammation, it causes neutrophils, chemokines, and all this release that we found. That raises the permeability, and through that you decrease there is a decrease in bladder capacity, and ultimately, over a period of time, you have bladder wall thickening. So this is Dr. Kuo's work. He did transmission electron microscope and the scanning electron microscope. You see in the IC patients, there are a lot of pleomorphic cells, large cells, small size, whereas normals, everything is uniform. And then there's the sort of apical lining is much thicker in the control, where IC is very minimal, and you can see the tight junction. And tight junctions is what through which potassium, urea, the gadolinium dye I just showed you, they all go in. And the thing is, bladder capacity is down because in controls you see this red star asterisk, that is discoid fusiform vesicles. So the controls can expand their bladder surface. These vesicles go on, they expand the bladder surface area. ICPBS are missing that. So what IC is missing is a mature umbrella cell layer. This small cell, they're not maturing. I'll come to this question again later. But the bladder wall thickening we studied in MRI through this black and white and color. We can go over this in discussion. So Dr. Kuo has been doing CT, focal thickening with the IC patient, and then he also does staining with Mason trichome. He's shown that thickening is because of fibrosis. And this on your left has a paper of IC flare-up patient who was not responding to prednisone, but they combined prednisolone with tacrolimus. It responded, and immediately at the later bottom CT, you see the thickness went down. So even chronic inflammation can also cause thickening of the bladder, not just fibrosis. So all this thing, again, I use this electron microscopy picture from Dr. Kuo published, then this paper from Son from California, they put fluorescein. You see the fluorescein bright, you see all the bright borders in the middle? That's only fluorescein is going through the cell borders. So the transcellular, the top surface, like the retaining wall, they are totally watertight. They do not get in. But the borders around it, they allow all things go in. And they follow what is we call it Stokesian and Fickian diffusion. Stokesian diffusion is basically size dependent. Things will go in size, smaller size, easy access, bigger size will be restricted. And Fickian diffusion is basically concentration gradient. And the bottom dx term is the distance. Because IC patient doesn't have an umbrella thickness, urothelium, the diffusion, or the length, tissue length, fluorescein, gadolinium, or potassium has to travel to the nearest blood vessel is very minimal. So as a result, diffusion is much faster in IC compared to the control. So those are the physics terms. I've been trying to explain them to my study section, but all my grant have been triage on that. So I hope after this they would be chimed. So, but this is Dr. Parsons' paper that in control subjects, they do not absorb. That's not true. They're just slower. If you see, compared to the IC subjects, if you let the control subject hold their urine for 5 hours, this was a control trial, crossover trial did in the UK, where they found if the patient, control subjects are peeing at 3 hours versus 5 hours, the amount of potassium they pee out in the urine changes. It actually is lower than IC patient. So, and even sodium also go down, but urea doesn't. So body will reabsorb from the urine whatever it needs. So just have to ask them to hold their urine for long. So that is, and this is a creatinine part. Just to reinforce, this was paper published earlier, that with inflammation, creatinine reabsorption also increases in rabbit. They not repeated this in humans yet, but that raises the question, why are we normalizing with creatinine when this absorption changes with normal and inflamed bladder? So this thing I want to bring up, because this was the reason why bladder permeability is not well accepted. And reason is this study was poorly done. The reason is, if you look at xenon on your left, they measure the time scale. At 5 minutes, it peaks. And I asked that question, potassium sensitivity. At 5 minutes, xenon levels in the exhaled air peaks. And you put potassium, the pain also peaks at 5 minutes, or at least 1 minute, as Dr. Parsons said. When they put radionuclide in the bladder, this was from Philadelphia, they measured the permeability at 30 minutes. There was no justification for that. They should have measured it at 5 minutes. And you say that 5 minutes, they compared the controls on IC, 2.232, 1.27. If they have done it at 5 minutes, they have found a significant difference. And the field would have been much, so there have been missteps in the past. That's why we are stuck with this permeability dispute, because we don't respect time. We don't measure at the right time. That's the reason. And this fact is even lidocaine. Lidocaine pharmacokinetics, they all measured after 30 minutes. Nobody has measured at 5 minutes. I couldn't find a serum levels of lidocaine at 5 minutes. So this is with the umbrella cell layer and the Hunter IC is there's too much proliferation going on. So the idea that to describe that is grow big or go home, or go big or go home thing. Either the umbrella cells have to grow big to survive, or they have to perish. That's why this paper recently, last year came out from China. They found HAS3, which is hyaluronic acid synthase, the yellow stain that you see, that is actually higher in IC patient than in controls. PCNA is higher. That means proliferation is higher in IC. GAG layer, or GAG in the urine, actually is higher in IC, lower in controls. HAS synthesizes hyaluronic acid, 2 matches. So these are aligned. So how do we verify whether there's proliferation is really an issue? You can do PET CT. I don't know. You don't have to take biopsy all the time. So cancer, you see the signal at 1 hour. Cystitis, this was eosinophilic cystitis, they see the signal at 2.5 hours. The reason is venous stasis. Blood flow to IC is compromised. This matches with other people who have done Doppler. The blood flow versus cancer is much slower, and that's why the signal is delayed. But to avoid that, if we don't want to wait 2.5 hours, we have put gadolinium into the bladder. This is Chris's patient, Hunter IC patient. You can see on the top without contrast. At 20 minutes post-insulin, you can see the enhancement in the Hunter lesion, and with MRI within 20 minutes. So these are the, from Dr. Mulvin, I thank Joel, Joel sent me this data. So this is the Hunter IC in unaffected control. What's the difference? So these macrophages, neutrophils, T cells, so they are attracted into the tissue by different chemokines that we can see them in the urine. I've listed it at the bottom, and those could be used as a biomarker. So this is the pathway that Joel would explain when the discussion question comes up. That's your responsibility. So this is the clustering of Dr. Kaur's work that we can use a finger, instead of just using one finger urine biomarker, have a different, combine the forces that actually maybe classify ICP-BS from dysfunctional voiding. So this, we can discuss this more. And there's a what you call decision tree, what the key thing here that you have to remember is none of these urine biomarkers have reached the sensitivity of potassium sensitivity test. You see the dotted line, they are 0.7, 0.6, and Dr. Parson was when we were coming back on the ride yesterday, he said this actually 80%, 90%, some patients are 100%. So these have to actually match the PST yet. So, and these things have been studied with hyaluronic acid, doesn't cause a change, but platelet-rich fractions, they decrease these. So these factors, they go down with there's a treatment effect on MCP1 and oxidative stress. So this is actually, Dr. Peters will recognize this data. So this was CXL when we did, now after that with the neuromodulation. So now MCP1 has come up recently in serum, people have studied. So and these are all the biomarkers that have been studied with global response after the post-treatment, and some of them perform better than others. So to conclude, objective phenotyping by bladder filling phenotype, bladder permeability, bladder wall thickness, it just all hinges on inflammation. If you cure inflammation, these markers will go down. So that's the should I say touchstone, or to verify whether these are real or just spurious. And phenotyping can accelerate, that's my personal opinion, don't blame others, and evidence-based medicine, and it reduces reliance on expert opinion. Because expert opinion is most times wrong, because it says permeability not increase in IC, watertight bladder, unreliable witness. Those are contradicted by convergence of potassium sensitivity tests, xenon peak, garlic smell, all at 5 minutes. then on lidocaine Cmax also at 5 minutes. So Horner lesion is a strong predictor of cyclosporine response. And antiproliferative factor and GAG elevation in urine, they may index injury and immature cells. Healthy cells do not rely on GAG layer. They have glycoproteins. So this is the GAG may be just like a training wheels. You don't need them in immature, but while the cells are very small, they are growing repair. That time they are secreting GAG. With that, I'll thank you all for attention and happy to take questions.
Thank you for the talk. I wanted to ask a question about urinary biomarkers, and I'm a little afraid to ask questions about it because that's not my area, but it's one of the most frustrating things about this disease that there hasn't been some substance identified that correlates well with the presence of IC compared to controls. And I'm wondering, so then the question is, what are we missing? And has anyone just taken a group of asymptomatic people and measured urine biomarkers over time to see if there are changes that occur to identify the stability of the measurements? And if they're not stable, then start looking at, so that seems to me like a fundamental thing of how easy it is to measure, or not easy, but how kind of reliable it is to measure things. Are you aware, or is anyone aware of that type of basic data that's been done?
Yeah, so that's a very good question. So the problem with that is, as I said, all this biomarkers sort of, that's my idea, it hinges on inflammation. If there is no inflammation in the bladder wall, controls you said, if the controls do not have inflammation, you don't expect TNF alpha to be high in the urine. But IL-8 and all that, they're very low otherwise. So that they are so low that they're below the threshold of even the test that you measure in the controls. So that you have an excellent suggestion, but if we have to test it, we have to test it in IC. We cannot test it in controls. Because controls don't have many of these biomarkers at measurable levels even. So that's the problem. And you said because of the IC has a heterogeneity, because they are so heterogeneous, we don't know how to bin them yet, how to put them in different classes. So and now this phenotyping that has come up, vulvodynia, bladder filling pain versus pelvic hook tenderness. So that's, I think, a good start. Once you clinically separate them, then it's much easier to correlate.
Maybe I'll ask a quick follow-up question. Has there been any movement to define a standard set of potential urine biomarkers that we all agree upon that should be included in studies? And so what can be frustrating is you have one group that reports on certain biomarkers, and then the next group, there's no overlap. Well, there's overlap in one of them. And it's hard to make progress if you have different groups studying absolutely different things. And so I guess that would be another question. Could this group kind of develop, what would be a list of, hey, if you're going to do these studies, please include these 10 things. Yeah. I don't think it's all that much more expensive to do that, I don't think. But anyway.
Yeah, and on this, Dr. Ko has, I think, led on that, and then he has published over the last few years. He has found some. So those are the promising candidates. Everything with the AUC value more than 0.6, those are good candidates to go with.
Hi, Dick Jensen, Netherlands. Hi.
Hi.
Hi, now Megan. Hey, I see as a conclusion here, and I think it should also be documented, that currently we all agree on that when there's inflammation, there's a permeability issue. But currently there's nothing that would replace either a cystoscopy or anything else that we can actually supplement. I would not do an MRI, a complex MRI, instead of a cystoscopy, for instance. So I think that's one remark that I want to give. So we need to study this, we need to continue, but currently there's no clinical implications whatsoever, because it will not change how we need to diagnose them at this moment. Second part is, and I always try to say that the GAG issue is much more complex than we think, and there's always these biomarkers that we try to simplify everything to make it fit a theory. But what you already say, like healthy cells don't need a GAG layer. I don't think that's true. I mean, there's a normal GAG layer, and if bladder becomes irritated and you get more turnover of urothelial cells, it gets more. So we investigate. There's a normal GAG layer in there. But if urothelium becomes damaged, then there's much more turnover in cells, so there's much more GAG synthesis, HAS3, and so on. So all these markers are actually correct. So if you remove with hyaluronic acid, with hyaluronidase, with enzymes, you get an increase in HAS3, you get all the EL6, 8s, and those kind of things. But I think it's wrong to assume that healthy cells don't need a GAG layer. I think it's essential that healthy urothelium needs a GAG layer, but when it becomes injured, it all goes into repair mode. And that's actually also what we see in our recently published manuscript, is that it promotes barrier molecules, those kind of things. So there's much more to it than to say that it doesn't need GAGs in normal healthy cell layer. It just gets a more increased turnover and more production of GAGs. And that's what you then see in the urine. So I think that's something to take into account.
So I'd like to respond to that. So what I meant was in controls, they have glycoprotein on their cell surface. Only the immature cells, they secrete GAG to entrap potassium and cations. Immature cells rely on GAG layer to prevent as a barrier. Mature cells do not. They have glycoproteins. They rely on perfusion to dilute.
They also have a healthy GAG layer.
Because that is not supported by data. That's your opinion. I would love to see your data. Let me show you your data on controls, not IC. In controls, show me a same chemical composition of GAG layer as you see in IC.
Yeah, no, we have just, I can show you my articles from 2012 and so on. We can visualize carnitine sulfate and so on. That's just as a deposit on the GAG layer with enzymatic removal, and so you can see a decrease in tear, in barrier molecules and so on, and really functional barrier diminishment. So I will show you, it's even my PhD thesis from back in the day.
It goes down in controls. As you show the HX3, it goes down. If it goes down, it aligns with the hypothesis that I'm going to make.
Yeah.
Joel Stern, Zucker School of Medicine. Just to go back to the question of finding modulators in the serum, in the urine, in the blood, in the tissues, this is something that we discuss, and actually if you read the paper, you'll find the answers. We came up with different modules, but we need to come up with a consensus of the cytokines, chemokines to look at. But it takes time. We can't just run it takes several days to weeks to run experiments. We never looked at longitudinal studies, as Quentin said. We need to do that. We need to look over time. We need to follow the same patients over time and look at the markers, but we do need to come up with a consensus. And if you read the paper, you'll find some consensus that we discussed as a group.
Yes, Marianne Alpern, UCSD, and I'm also part of this group. One of the important things that we wanted to highlight is that, as we talked about, there's a disease progression, so your biomarkers will change, and maybe your bladder capacity will change as well. Since we don't evaluate it longitudinally, we don't actually know if the person with the normal anesthetic bladder capacity at the beginning will not lose it as the disease progresses and you develop fibrosis. So an important part is that when we can come up with a panel of the biomarkers, a lot of these biomarkers are not run by the standard laboratory tests. So we need to make a case for why they should be incorporated in a clinical care. Because a lot of these biomarkers, we now know that MMP9 is upregulated, for example. And then, Steve did a lot of work to show that there's an abnormality in small nerves, etc. There's so many different things that you can look at that also secrete things that you can get in the urine or the serum, but they're not part of the standard clinical care. And so we need to find the ways for to be covered. And then we can do laboratory longitudinal testing during the flares and not flares, and also would be very helpful to see what goes up and down.
Yeah, and we proposed what cell types go up and down. So in HIC, you can see all of these different immune modulatory cells actually going up. So we'll see T cells increasing, we'll see specific Th1 cells increasing at the site of the Hunter lesion. This is all based on histology. And we'll also see the presence of NK cells and monocytes. So we'll see all of these cells, but again, is it before or after? We don't know what's driving this response. So if we look at the MHCs, we don't know the antigen that's causing this inflammatory response. So maybe the group can come up with some triggers or initial antigens that can drive this response. Because the inflammation's occurring, we don't know why it's occurring. But we see this as an after effect, we see all these different cells being increased. And we compared that to non-Hunter lesion groups. Okay.
Can I make it? Dr. Peters is going to get upset with me, but like Dr. Clements, this is not my area of expertise, but I just have a couple of basic questions. That slide is a prior biopsy site. It's not a Hunter's lesion. Anybody read Hunter's original papers? I have. It's a red patch. It has no radiating spoke-wheel blood vessels. It has no fibrosis. That was biopsied and maybe 3 years ago. The bladder heals poorly when you biopsy it. It's not a normal bladder. The potassium is interfering with it. You can look in 3 years later and see a fresh biopsy that was done. Or it looks like it was done recently, but if you do a bladder tumor resection in a normal patient, it heals the same way. The body always heals with scar formation. First you get the vascular phase, and then you get the deposition of collagen, and you get the radiating spoke-wheel vessels in the bladder going towards the biopsy site, and it ultimately should heal with a small scar and a few radiating blood vessels left. That's what a bladder tumor resection area looks like a year from after you biopsy it, but it doesn't happen. So everybody's calling the wrong thing a Hunter's lesion. It's somebody biopsied the bladder because they're a fairly symptomatic patient. So you're looking at a lot of artifact here. That's one question I have. So I wasn't going to ask that question. The other is, in the urine, when you're not looking at this, where do you think the antibodies, or where do all the cytokines come from? Where do all the inflammatory products come from? They don't come through the glomerulus. They don't come from the ureters. Do they come from the bladder wall? They won't go through the epithelium into the urine. Where do they come from? Are they coming from white blood cells?
Well, the white blood cells are extravasating through the vessels into the area. They're being summoned through chemokine and chemotaxis.
Yeah, but
And
where
then they
are the
would
white
secrete
blood cells?
the
When you
what-
collect a urine specimen
It's the factors that are secreted.
by white blood cells?
It could be other cell types.
Could be other, what cell
But the
type?
majority of cell types would be the white blood cells, such as
Right.
the T cells, and you mentioned whether there are antibodies. So there have been reports on antibodies that can be detected in the urine and also the peripheral blood.
Well,
And those
I'm
are,
talking about,
those would be
actually,
B cells.
I just meant
Those are the
inflam-
B cells that produce the antibodies. But the thing is, what are the antibodies specific to? That is the main question we have to understand. So there was a report that showed that uroplakin could be an initiator. And then
That's-
so there was a study
That's
that was
not
done
really
a
my
few-
question. My question is, where are the inflammatory mediators? You're measuring urine for inflammatory mediators, correct?
You would take blood, you would have to look at the
No, I'm
blood.
talking about the urine.
You'd have to look at the urine, and you'd also want to look at the tissue. So
I'm
you'd look
talking,
at
I'm
three
talking
factors.
about when you're looking for a urine marker, that means they're coming from the urine. That's what I'm talking about.
It could leak into the urine, and it could just appear, and we don't know the full process we don't know the full mechanism of how everything gets everywhere. We know that if we measure the blood, we have white blood cells there, and they're producing cytokines or chemokines or other factors.
Well, the urine factors can't come, they can't come from the glomerulus. They're not coming from the kidneys. The urine factors of inflammation don't come from the kidney unless the kidney's
But
inflamed.
the immune cells do extravasate to different sites and produce
The what?
these factors. Huh?
Well,
They move to different areas, and just because a cell is not in the bladder doesn't mean that it's not producing factors that can cross and leak into the urine.
I'm not following you. How do they get into the urine? Not through the kidneys. They have to come from either the bladder or the ureters, or?
So let me answer that question with the nerve growth factor, actually. Nerve growth factor has been studied in the urothelium and in the urine. So that we can trace nerve growth factor to the urothelium directly, being released during the exocytosis, expansion and contraction of the bladder. It gets released into the urine. That part we know. For other things, that needs to be studied. But for nerve growth factor, we know.
And so one last error that you can make, or there's a potential source of error is big, is that if you're measuring urine for these levels, how do you collect the urines? If you collect them by catheter, you'll probably get a pure specimen. If you let a woman void, you're going to collect whatever's in the introitus, including white blood cells, which could be the source of inflammatory markers that
Thank
you're
you. Maybe we
detecting.
could take this offline, and we could have a conversation afterwards.
Laurie, let's just finish the two talks. Go ahead.
Yeah, so not to actually another layer of complexity, but we know that the urothelium, for example, can secrete a number of factors, whether or not cytokines, but certainly prostaglandins, nitric oxide. I mean, there's a whole laundry list. So I just wanted to mention that things can actually affect this besides the disease process, besides inflammation, but certainly diet, we know that can influence the release of factors, and even chronic stress. So in terms of Quentin's question before, I think it's a good idea to have some knowledge about some longitudinal assessment in a particular patient over time, not just for inflammation or the disease, but in terms of what other factors can influence these release over time, which we don't really know.
Right. Thank you for your question.
And my comment really builds on both of those, which is in endometriosis, the search for non-invasive biomarker has been like the holy grail of research for decades. And one of the problems is that no one collects their samples in the same way. The clinical information you collect to align with that is different, and therefore we've not been able to combine data in big samples. So there's been an international agreement on clinical data collection tools and specimen collection tools to allow people to align their samples. And if you don't have that within IC, then I think it would be fantastic if you could adopt the endometriosis ones, because we know there's so much comorbidity between these conditions, then that would actually allow us to combine all the data together. And there's recently been a clinical examination tool released as well, which covers all of the things that was discussed earlier about how to assess pelvic floor muscles and things. So if there's a way of us aligning those tools, that would be fantastic.
No, thank you for that question. And actually, if you take urine samples at different times of the day, you'll actually change the cytokine outputs and levels. So levels fluctuate throughout the day and night, and so I think maybe we should align our approaches to try to standardize everything. So at least when we find some proteins, we know that it's more reliable. Yeah, thank you. Thank you for that.
I just have a very brief comment about what our respectful Professor Parson talked about, the original Hunner's lesion. Is it possible that Guy Hunner didn't have the optics that Magnus Paul had it in 1981, and he described the Hunner's lesion in a different manner? Just a food of thought. Thank you so much.
Thank you.
Okay, I see the inflammation is rising and the levels, which is a good thing. My suggestion would be that lots of you have great suggestions for each of these committees. Maybe you can post some questions that each committee should answer in their paper or revision paper, and you can route it through Caroline or directly to the committee. Also, I think each paper should at least end with a query or a question or a research that you'd like to see followed as a consensus opinion. So that would be great. Let's move on to the next committee. This is ICBPS in males. Dr. Taneja is going to lead the presentation and discussion.
Good morning, ladies and gentlemen. Thank you very much, Dr. Padlani, for giving me this opportunity. I hope I can start the presentation. Can somebody help me with my presentation? Yeah, this is the one. Yes. And then right here. Yeah. Great. Yes. Thank you so much. So, when I was given this topic, I know why it was given, because I have certain series in which we have a lot of men, and we have reasons to explain why do I have that. But let me start with the background that it is primarily a disease of women, to the extent that when there were groups starting off for interstitial cystitis, the gynecologists were quite well involved, because it was thought, and it is still thought, that it is primarily a disease of women. And quoting the 1978 Campbell, it says that interstitial cystitis is the effect of hatred, which is manifested at this in women. I thought it was a very harsh statement, but then today we are here to discuss that it exists in men. So obviously that statement has had a half-life. And recent literature suggests that increasing prevalence of ICBPS in men is actually true, and we do not have tailored guidelines for men. And it is not as rare, as I mentioned. And there's a range of prevalence. If you look at the prevalence in various studies, the range is 150-fold for women across the globe, and it is 500-fold for men. This itself shows how confused we are. And that is the reason that we are here today for a consensus meeting, because we still do not know answers for a lot of them. And these differences could be because of the differences in definitions, differences in methodology employed, and of course, we have frequent misdiagnoses. So we need to go through them bit by bit. So I'll quote this paper by Clements in 2007, where 10,000 patients in a managed healthcare population. Now, this is one difference I see, that you have managed healthcare population and you have actual general population. So the incidence and prevalence are going to be different. And of course, they utilized two definitions, the sensitive and specific. I'm not going to talk about it. And they found a female to male ratio of 5:1, which makes it was initially 10:1 to begin with. But then this is the first time in 2007, this was paper which came as 5:1. And then the Boston area community health survey, which was published in 2008, talked about a ratio of 2:1. They looked at 5,500 population adults in the Boston area. And then this is the RAND study, which was published in 2013. And they looked at 100,000 US households. Again, it's a general population. And they found that the ratio stood at 1.42 to 1.5. Again, almost 1.5 times to 1. So this was gradually increasing incidence of ICBPS in men. And with this estimate, it was thought that at that point of time, almost 2 million, a little more than 2 million men were suffering from ICBPS. And there is this population-based study by Jennifer, who is sitting here, who talked about female to male population ratio being 1.6:1, which is almost the same. This is the reason why I'm here, that in the last conference, one of my residents looked at this ratio in my clinic, and it was 0.95 females to 1 man. So this is something which was different. Perhaps it is because I'm at a tertiary care center. I'm attracting a lot of functional urology in men, and I have an open mind to diagnose, and perhaps that is the reason we should be here. So what are the gaps in literature? Obviously, as I was talking, that you have questionnaires for diagnosis which are self-reported. Now, if you look at the validity of questionnaires, I'm not talking about the scientific validity. If you give that questionnaire to one person today and the same question to same person maybe another day, the responses would differ. So these are differences that we will, if we go by the patient-reported diagnosis, I'm not talking about anything else, it is just about the diagnosis. And therefore, if you look at the literature, when I was going through the search, I realized that the diagnostic criteria are different in different studies, making possibility of contamination of the data by non-ICBPS patients. And of course, there are differences differences in the definition. I'm glad we will arrive at a consensus today. And of course, there are confusions because of the healthcare registered individuals and the general populations. Coming to the clinical features specific to men. Now, there are data which suggest that men will complain of pain, women will complain of pain plus bother. The pain in men is more focused, and pain in women could be more diffuse, with a lot of reaction to that pain, the psychological reaction. And of course, there's a difficulty in the patient the physician bias. If you are a functional urologist and a man walks into your clinic, you will not perhaps think of bladder pain syndrome. You will perhaps think of something else. And that is where we have a series of studies which talk about misdiagnosis in men. And up to 48% of men which was previously diagnosed as prostatitis or previously diagnosed as BPS undergoing TURP, urethritis and epididymitis, they were actually ICBPS. Now coming to the story of urologic CBPS, where we think that there should be some difference. And if you look at the urological BPS, it is pelvic pain, LUTS, nocturia, sexual dysfunction, widespread pain, non-neurological comorbidities. It does not talk about the relationship of pain to the micturition cycle, and that is where the whole confusion starts. That is where the differences in the prevalence rates are. And Malvin in 2003 addressed this point, pointed it out there. So coming back to the clinical features, if you have pain and if you have lower tract symptoms, if the pain is not related to the micturition cycle, it is unlikely to be coming from the bladder, and that is important. The symptoms, as I talked about, were more severe in men, and of course there's pain on filling, relief on voiding, forced voiding, the distribution of pain, and of course these patients will have intense discomfort as compared to a fear of leakage when they are asked to withhold, and they may wake up from sleep due to pain and not due to the full bladder sensation. Of course, there could be other things like bladder neck and pelvic floor spasm, which cause hesitancy and prolonged voiding, which results in frequency, persistent desire. And as we know that if you go deeper into the character of the pain, you can find that it could be pricking sensation, or it could be related to posture when you know that there is something else around the bladder which is happening. So 50% of women would have their pudendal nerves exposed to the pelvic floor. This is an anatomical study. So when the bladder fails, there is an irritation of the pudendal nerve, and there is a pain which goes to the pudenda, and the patient learns to go and pass urine. And this is aggravated on sitting and standing. So this is how this point has been brought here. We are not sure how much it works for men. Of course, suprapubic tenderness on examination remains the key feature. If the patient has a bladder pain syndrome, interstitial cystitis, you will more often than not find a suprapubic tenderness. And the digital rectal examination, one has to learn to identify anterior rectal tenderness against prostatic tenderness. And of course, one can find tenderness in the perineal body. So one of the commonest differentials with ICBPS in men is prostatitis. And as I was mentioning, we need to focus on LUTS and pain in correlation. That means with the micturition cycle. So if the pain begins with the filling, it is perhaps originating from the bladder, but if it is commencing on urination, then perhaps it is the first drop of the acidic urine going into the prostatic urethra, which causes burning and pain. So these are finer differences. You need to talk to the patient. Patient is not going to be giving you this answer very quickly. You may have to spend time and extract this information. Painful ejaculation can be seen in both, but is more common with prostatitis than ICBPS. And of course, in prostatitis, there is hardly ever a suprapubic tenderness, whereas on DRE, there is a prostatic tenderness. There may be prostatic tenderness, but anterior rectal tenderness is indicative of a bladder pain syndrome. So obviously, this has been picked up, and Clemens has published in 2022 that about 75% of male participants of CPPS were actually having painful bladder filling. And that is where we are starting to differentiate that. Now, if you look at the records, I'm talking about the US data, 9% of the urological visits are chronic prostatitis. Even if it is a small percentage of them which are actually ICBPS, you can understand the number of ICBPS patients that we are not diagnosing, and they have their problems with delay in diagnosis and overall outcome. And there comes the question. I have not used this for this particular reason, but maybe there would be a role of lignocaine test in these men to differentiate between chronic prostatitis and the bladder pain syndrome. We don't have the data as yet. And of course, clinical phenotyping, we have talked about there should be scoring system, there should be non-urological morbidities, and we have actually I have talked about the phenotyping based on etiopathogenesis. We must have sexual dysfunction in all the scoring as we have. And of course, investigating these men with bladder diary and mapping of the pain and comorbid health conditions. These all should be part of the workup of these patients. And we must exclude infection with the presence of either leukocyte esterase, nitrite, or pustules in urine. That means there is an infective pathology, and we must do everything for a microbiological diagnosis in these men. On the other side, if you have pus cells, but the culture is sterile, it is not the culture alone which decides whether it is infective pathology or an inflammatory, non-infective pathology. In men, we need to exclude obstruction. Ultrasound comes in a big way in doing that. Treatment is not going to be different, except for the fact that anticholinergics should be used with caution in men. And they increase the residual urine. And, there is a literature which talks about it does not cause retention. But if you look at successive literatures with the production of release of one anticholinergic molecule after the other, each one mentions that the previous one caused a rise in the residual urine, but the new molecule is not causing. And when mirabegron was launched, the papers in the publication showed that anticholinergic was causing rise in residual urine, but beta-3 agonists were not. So obviously, the literature is fluid on this. We all have seen patients who would suffer because the bladder is not emptying properly in bladder pain syndrome, where the pain persists because the bladder is not emptying. So one has to be careful. And of course, there is underrepresentation. As of now, these are the gaps. We have small sample size, no separate analysis of men versus women. There's a lack of gender-specific trials. There's potential misdiagnosis. There's a different pathophysiology, perhaps, which needs to be seen. And male-specific trials are needed. There could be hormonal and anatomical factors in male ICBPS. Thank you so much for the opportunity.
I would like to congratulate to Rajesh. This was a marvelous summary of this topic.
My group
I enjoyed it very much.
The credit goes to my group.
I just would like to add a symptom which, as I saw, was not mentioned, which is quite important in male patients. I have much less male patients as women, but I remarked that one of the leading symptoms in male is urethral pain. And this is quite typical, and during the course of the treatment, it also disappears. It's important to mention the bladder symptoms disappear sooner than the urethral symptoms. And this may make the catheter-free installation method more important in male patients than in women, which is already available. Thank you.
Thank you, Lovash. I know you have that equipment developed which causes catheterless installations, and I'm sure in times to come that's going to take wider application into the masses.
Rajesh here.
Hi, Sanjay.
So, hi. So, wonderful presentation. So, we recently, very recently published the first large multicentric paper on a cohort study on young men presenting with lower tract symptoms. This was 16 centers, about 440 odd patients published in the Indian Journal of Urology. And one of the things that we looked at was, we administered was the ICSI and ICPI question 4 to these patients, along with a non-bladder myofascial pain VAS score. And we were surprised by the percentage of men who actually responded with pain. These are men who had presented with lower tract symptoms, not with pain, but almost 70% of patients both marked the ICSI and ICPI question 4 showing pain. Even the non-bladder myofascial pain, about 50%. So it's quite possible that some young men are actually presenting with lower tract symptoms when primarily they have an underlying pain which they are not able to recognize. That's one thing that I wanted to talk about. The other was regarding prostatitis, and the misdiagnosis. Prostatitis is almost like the hysteria of the what was hysteria in the 19th century is prostatitis to men in the 21st century. Everything gets labeled as prostatitis, even when there's absolutely no objective evidence to connect the patient's symptoms to the prostate. And finally, I think the urodynamics needs to be utilized better in the male population especially. We know that a lot of patients get a TURP unnecessarily when they actually have BPS. But the other way around is occasionally also true, that patients who are actually obstructed do not get a treatment to relieve obstruction, which could potentially improve symptoms and also facilitate the management of ICBPS once you relieve obstruction, because they have not been assessed by urodynamics.
Thank you, Sanjay, for that, supporting our view that it is increasingly diagnosed in men as ICBPS and the younger men, because as there was this slide that we should do cystoscopy above 60 years of age, I think we have to relax that and we have to think of younger men having ICBPS. Thank you for that. Yes, sir.
Very nice talk. And, men are challenged having the prostate there. And again, labeling men with prostatitis is just labeling, it's a similar issue of labeling women with interstitial cystitis based on pain. And I always find it intriguing that, the vast majority of men under the age of 50 who go to a urologist walk out with a diagnosis of chronic prostatitis. I mean, Curtis would know better than me because I don't remember all the details, but I mean, years ago with the NIH, we did a study like, doing prostatic massages, looking at inflammatory mediators in control patients and active patients, and really found no differences. And I think that when the prostate hurts, and again, I think so much of what we do here could be helpful if we make practical recommendations to clinicians who don't usually do this. Because you could push on the prostate, and what are you doing? You're stretching the pelvic floor. So I would say if the prostate hurts, they need to swing their finger to the side and feel the pelvic floor muscles. Because just like in women, this high percentage of these men have significant pelvic floor dysfunction, so they get ejaculatory function, they get voiding dysfunction, ejaculatory pain with the spasming of it. So I think we really need to harp on that initial, you can't make a diagnosis of IC by seeing somebody for 5 minutes and doing a potassium test. You have to do an exam and get a good history. And the last comment I'm going to make is, because we didn't really address it here, is Hunner's lesions, because they do occur in men very similar to women, and they come on very quickly in an older population, and you get a rapid degradation of the bladder size, which is truly an inflammatory disease. And so I have lots of men and women who are, been treated for Hunner's lesions on cyclosporin, or, ultimately had cystectomies in some of them. But I think we need to really address the issue of Hunner's lesions, that you need to do cystoscopies in somebody who you might suspect.
Thank you so much. So both the points I'm going to address. The first is very well taken. The methodology of digital rectal examination is what you were pointing on, and Madeleine is going to make point about it. So differences between the prostatic tenderness, the anterior bladder tenderness, and the myofascial tenderness. So these are the three things that you achieve by DRE, and we are going to dot that in our one. The second one is about Hunner's lesions. So I don't want to present my personal data, But my personal data, I have 50% of Hunner's lesion come in men and 50% in women, and they do extremely well with whatever treatment we do institute for women. They are doing well with men also. So I fully agree with you, and we can put a label, a line in our script about Hunner's lesion. Madeleine is making notes. Thank you so much. Hi, Samarinas.
Michael Samarinas from Greece. Thank you for the presentation. It was an excellent chairmanship in the group. We have a teamwork, excellent. Well, I think that in the male ICBPS, the key is the pathophysiology is more complex because you have the prostate. And even if we are talking about biomarkers, maybe even the inflammation markers could be a complex way to find our fine conclusion. So we have prostate, maybe BPH, maybe prostate inflammation, and maybe the adrenal activity, maybe bladder inflammation. Which would be the right biomarker? Where is the origin of the problem? I think it's more even complex that it can be discussed here. So I think one concurrence could be only with inflammation, the lower urinary tract symptoms in men. Also, I have again to highlight, following the previous speaker and Mauro in the beginning, we have to emphasize on the urodynamics, especially in men. We have to show the obstruction. So it's not to have unnecessary surgeries, but in order to, moreover, in order to give the patient to understand the pathophysiology of this problem, of his problem. The urodynamic study, I think, is the only way to show him, and so as to avoid unnecessary treatment. Thank you.
Thank you so much. Your point's well taken. And regarding the markers, because it was not under the purview of our chapter, we didn't do that. Regarding urodynamics, yes, again, because it is going to be discussed by another team, so we did not bring it here for that. Thank you so much for the comments nonetheless. Yes, ma'am.
Thank you. And I'm on the committee, but I just wanted to make a comment, and such an amazing job our residents, Maddie and Wyatt, did. This is a really great example of sex as a biological variable being a priority from NIH, or at least it was. But when we look at so many different conditions where women tend to be undertreated, a perfect example is heart attack. It was considered a men's disease, and then women are more likely to have mortality. And you see here, because it's considered a woman's disease, men with IC have worse care, they're undertreated and significantly underdiagnosed. And so I think this is a really, this really important example
I'm
of that.
wearing this today for that.
I love it. And one other thing, and when Maddie did that literature looking, we had to go back because we're like, where's all the data? And it's all lumped in together. All the prevalent studies lump all the symptoms together. And we look, we treat women with IC. For me, a huge goal is, can you have penetrative sex? And with men with IC, that's not really as much of an issue. They don't have that kind of pain with sex. So I think once we have a better handle on the disease, we can tailor our goals of therapy.
Thank you so much. As somebody else also mentioned, whenever a man goes to a urological clinic, he relates everything to the prostate. So the disease starts towards that direction. And when a woman goes to the urologist, she talks about the bladder. Perhaps that has been the primary wedge that was driven into the two diseases and two different kind of diseases. And I agree with you that yes, we need to be more careful in our definitions for prevalence, as I have been emphasizing. Most of our confusions, and perhaps thanks to that confusion that we are here today, is because we did not have a perfect diagnosis till date, but now I'm sure we look forward to a very good diagnosis, which we all are going to accept and utilize in our data capturing from the times to come. Thank you so much, Jennifer.
Rajesh?
Yes.
Hi, thank you.
Kasyan.
Thank you
Yes.
very much for this comprehensive presentation. George Kasyan from Moscow, urologist. First question is, do you consider bladder outlet obstruction as a comorbidity, or it's like a kind of part of the disease? And second is, do you think that proper male group would work better on biomarker studies? Because we don't have this big overlap of UTI So could be we should work on male groups to find out proper biomarker.
So two things, Kasyan. One was, thank you for the questions. First one was?
First one was, do you think that this is comorbidity?
Comorbidity. So it is actually an associated pathology. It may or may not be contributing to the bladder pain. But while we are focusing on bladder pain, if we do not focus on obstruction, then we are not doing justice. It is just to remind that it exists. For example, if the bladder pain is actually happening because the bladder is distending, and if it is not allowed to collapse due to an obstruction, your treatment is not going to be effective, and the patient is continuing to have pain. The second point is about the biomarkers. As we mentioned, that 50% of at least my series had Hunner's lesion in men, which means that there is a pathology in Hunner's lesion. It's an entirely different pathology. And we will have biomarkers similar to women. Regarding the infection, yes, we do have infective prostatitis also. So I think whatever we are going to do for biomarkers in women will have to be done for men also. There's no way we can, at this point of time, I believe that this is what should be. Hi, Jansen.
Hey, hi, Rajat. Hey, I saw a lot of the prevalence studies and so on. I think it's really tricky and potentially damaging to just rely on surveys and just questionnaires to find out how many bladder patients or male patients there are, because I don't think there's any questionnaire that can distinguish between a CPPS patient, like a prostate pain patient, and an IC patient. So I think there's a lot of mix-up within the two, and I think it's really important to separate the two of them, because if you don't do any cystoscopy, you don't see, you see a majority of it's perineal pain, that's mostly the prostate, that's the problem, and also the pelvic floor problems and so on. And it's really, I think it's really important for us to differentiate between the two. And all the patients I have done a survey on 200 patients with the patient association, and we saw all male patients diagnosed by urologists, they almost exclusively have 100 lesions, and that's about 1 in 10 that we found. But it's the undiagnosed part. So probably there's a whole group of male patients indeed that have inflammatory bladder problems, but they are misdiagnosed because agglomeration also occur in severe BPH cases and so on. So that makes it tricky. That's the undiagnosed group, and I think that's the one that you should be focusing on, and that's probably why you're also thinking about this. But I think it's really important to separate the two, because I get the feeling that we are putting it on the same heap, and I think it's perineal pain is very typical for a prostate and also like a chronic non-infectious prostate type of problem, and not a bladder problem. And again, we're talking about pelvic floor, secondary problems, LUTs and secondary LUTs. So it can be a mix and so on. But I think we should try to separate the two of them, because otherwise you're going to dangerous ground and treating male patients for bladder pain syndrome or an IC disease while they don't have any IC and so on.
So thank you for your comment, Jensen, but I can tell you that it was published by Clemens in 2022, 75% of what was urological CPPS had pain on bladder filling. We are talking about men actually.
But did they then have...
And I fully take your point. In fact, one of the first slides was that these questionnaires, the methodology that we have used needs to be questioned. So I fully agree for you to be pointing it out again. And whatever data is there, my job was to get that data out and show it to you. But in the heart of hearts, I know that data, the basis of that data may not be impeccable and tenable all the time. So your points are correct, and then need to have a methodology of diagnosis before we talk of statistics.
And should you then do a cystoscopy in all male patients to find out?
I do that, but I don't know about ESIC. Mauro is here. I'm sure the ESIC recommends, the Japanese group also recommends cystoscopy in every patient. They have their own methodology. I'm sure you would know that if you look at those guidelines, they would be there.
Yeah, thanks. Sanjay Pandey from India. Wonderful presentation. Thanks for opening up this subject. But to the committee, I've got two things to ask. Number one is that the era of prostatism word is gone and LUTS has walked in. Men will always be taken as LUTS first and then comes to bladder. Is there an algorithmic approach that you have as a committee to give us this lead that we look into this subject in men earlier than what we do in the era of doing TURPs? And number two is, why is that sentence called antimuscarinics to be given with caution in men? How does that actually correlate it?
So I've just mentioned, I actually described it, that antimuscarinics will give rise to increased residual urine. And if you have an increasing residual urine, it will increase the pain because the bladder is not allowed. And there are so many papers which talk about it doesn't cause retention. But if you, as I said, every new anticholinergic molecule that is released, around that time you have papers that the previous anticholinergic molecule was causing retention, this one doesn't cause. So obviously, we don't know what is the truth. But the fact of the matter is that you, me, and everybody who is working very closely with the patients in the ER would know that there are patients who come with retention sometimes which are drug-induced. We have all treated them.
So this may be a very simplistic question. Why isn't PSA utilized as a discriminator to put to rest the prostatitis issue in these patients? I don't see it mentioned in any of the...
Yes. Actually, we had discussed amongst the group, the PSA is a non-specific entity. That's number one.
I agree. I'm just saying a negative one sort of puts to rest, and for the patient and the referring doctor, the so-called prostate word.
PSA, I looked at it, and is rising in infective prostatitis. In non-infective prostatitis, this is the issue. So, but we can put it in our group. There's no point.
My thought would if it is normal or very low, as
I
most of
don't
these
know
young
if it
patients.
excludes inflammation still. I'm not too sure. We will need more studies. Perhaps one of us can take it up and present our data. As of today, I'm not sure if that works. Yes, Klaus?
Thank you, Rajesh, for extending our focus to men from women. I have a question if children are not affected. I had a girl with BPSIC and there are publications on children. And the question is if our group should not have a statement about BPS possible in children too.
Yes, so we all know that there is a pediatric population suffering from bladder pain syndrome. So I don't know whether I should include it in my group discussion, but I think it is for the general other groups to take care of that part, especially the definition part where exclusion was less than 18 years. That sentence has been omitted, I think. So that's good enough. Yes, Clemens.
Just a quick comment. That one study you showed from Rayan, the Susskind, with the prevalence of IC in men, we also asked questions using a definition Curtis had developed to address the prevalence of chronic prostatitis in that same population. And so there was overlap, as you'd expect. I think the prostatitis symptoms were somewhat higher. I don't remember the specifics. But in terms of that question of, to what degree is it prostatitis versus IC, at least that study would look into that a bit. The other related to PSA, I'm pretty sure one of those, that the older cohorts looked at that, because the real question is, are we looking for, comparing the type 3 prostatitis, chronic pelvic pain syndrome, and that what they showed is there was no difference in the PSA values between those patients and those without the symptoms, with the concept of that there's no increased risk potentially of prostate cancer in the group. So I'm not sure that we can use PSA as a way of trying to help discriminate, unfortunately.
You say that it's not infection, inflammation, or prostate cause as a negative marker, not necessarily making a diagnosis. I'm just saying if you get a PSA 1 in this young person, you can tell him, well, it's not prostate inflammation. That's the purpose.
The comment that I would make is this. At the time of the Rice study, when we looked at the high sensitivity number, it came out at a little over 8 million. And concomitantly, the incidence of CPPS was 7.8 million at that time. And when I take a look at all this, the question I have is there any difference whatsoever between CPPS 3B and IC? Because I think they're the same thing.
Sorry, I missed the last bit. Do you think you're talking about the coexistence of CPPS?
I don't think there is any difference. I think CPPS type 3B, which we used to call prostatidynia, I think that and IC are the same thing, which would, to me, indicate, given those numbers, that the incidence of male IC and female IC is probably identical.
So when we, it's about the CPPS3, which...
Please stop that.
Sorry, Curtis Dickel I can't let Bob get away with that as a last statement. Sorry, I spent 40 years looking at men with this condition, and CPPS is not all CPPS is IC. No, I don't think so. We've never been able to differentiate between type A and type 3. I think basically we were on the right track at one time when we were looking at male chronic pelvic pain syndrome and female chronic pelvic pain syndrome, and then we look at the different phenotypes within each. That would have been a better approach when we were back looking at urologic chronic pelvic pain syndrome. If we had continued with that, we might have had a better approach to men versus women. But, Venus and Mars are in different places in the sky, and it's the same thing with male and female
We'll take away time from your committee, all right? All right, thank you very much, Rajesh. So next presentation is by Professor Akiyama on the group on genomics and histopathology.
Hi, thank you everyone. Our subcommittee is genomics and histopathology of the ICBPS. And I apologize all members of my subcommittee because I haven't circulated my presenting slides to all members. So my presentation, regarding on my presentations, I am only responsible for this presentation. And I am presenting only the morphological changes in ICBPS and genomics, and not mention about molecular changes because it cannot be seen. So ICBPS, it's a very symptom syndrome complex and can be categorized into the Hanner region disease and other forms. Is this standard consensus? Yes, I believe. And yes, the non-Hanner region diseases falls under the ICBPS umbrella, and it's included in the chronic pelvic pain syndrome. But yes, the Hanner region disease is also included in the chronic pelvic pain syndrome. But I think it is a distinct inflammatory diseases as I am showing for us. So it's an overview of histology of ICBPS. This is a biopsy specimen figures biopsied from the Hanner regions. It's showing the dense inflammatory infiltrates and the, sorry, it's here. Okay, and detached urothelium, and some fibrotic changes can be seen. And meanwhile, it's non-Hanner region diseases. Shows little or subtle inflammatory changes. And some detached urothelium can be seen, but it is an artificial effect processing the histological procedures. So it is not as etiopathological changes for the non-Hanner region diseases. So the Hanner region disease is histologically a distinct inflammatory disease is characterized by the lymphoplasmacytic cell infiltration and epithelial denudation and neovascularization. And surprisingly, the same inflammatory changes can be seen not only in the Hanner region, but also in the background mucosa, i.e. the non-Hanner region area. Meanwhile, non-handle region diseases, also referred to the BPS, bladder pain syndrome, is histologically non-inflammatory disorder. When I say the non-handle region disease is not an inflammation disease, some may repeat to me, no, the mild inflammatory changes can be seen even in the non-handle region diseases. Yes, I know, but it doesn't indicate that non-handle region disease is related to histologically the inflammatory diseases. There's some histological changes can be seen in the many various bladder diseases. And this is the quantitative data of the lymphoplasmacytic cell infiltration. And you can see in handle region diseases, moderately severe lymphoplasmacytic cell infiltration and pancystitis, as I said, is similarly inflamed in the background non-pharyngeal mucosa out of handle region. But in non-handle region diseases, it's BPS, subtle to mild lymphoplasmatic cell infiltration can be seen. So very different, distinctly different inflammatory changes between the handle region disease and non-handle region diseases. So about epithelial denudation, yes, handle region diseases shows epithelial denudation, and also the denuded epithelium can be seen in non-region area. But meanwhile, in non-handle region diseases, epithelium is preserved, and yes, you can see the umbrella cells on the surface of the urothelium layer. So next, I'm talking about mast cell myth. So do you think the mast cells plays an important role in the pathogenesis of the ICBPS? I'm not sure, but mast cell count doesn't have the very, very important diagnostic value in the ICBPS. And yes, not only our team and also the Dr. Gamper reported in Journal of Urology 2015. Yes, in handle region disease, we can see the dense lymphoplasmacytic infiltration. It's accompanying the mast cell infiltration. And mast cell count is increased only in handle region diseases compared to the control or non-handle region diseases. And the mast cell count in non-handle region disease is equal to the normal bladder or normal bladder mucosa. So a short summary, so a distinct histology between handle region diseases and non-handle region diseases can be observed. And so lymphoplasmacytic cell infiltration and also the mast cell infiltration is increased only in handle region diseases, but not in the non-handle region diseases. So the another characteristic feature of the handle region disease is pancystitis. It is very important. So, and the inflammatory changes and the epithelial denudation can be seen in the non-handle region area, so background mucosa of the handle region diseases. And non-handle region disease, it is histologically not inflamed. And so next, neurogenic inflammation in ICBPS. Dr. Gamper also reported in 2017 sensory hyperinnervation in handle region disease and the non-handle region disease. It is very interesting. So yes, handle region diseases, there are severe inflammations, and also it is accompanied by the sensory hyperinnervations detected by the antibodies using the PZP 9.5 and the P75 MTR. And this is a mast cell infiltration, and also the sensory afferent nerves can be detected right here at changes. And interestingly, in the non-handle region diseases, I think they have seen the bladder-centric phenotype of the non-handle region diseases. Close vicinity in the mast cell tryptase positive cells and sensory nerves can be seen. But unfortunately, no MCT IHC figures were shown in this manuscript. So next, and vascularization, the fibrosis, and ICBPS. So neovascularization in ICBPS, it's also upregulated in only Hanna region diseases. And yes, and IHC using the CD31, it's detecting the microvessel density, and IHC using the VGF, and the positive cells only upregulated in the Hanna region diseases. However, some literatures reported the increased fibrosis in non-Hanna region diseases. This is a report from South Korea. Non-Hanna region diseases manifest the severe fibrotic changes without severe inflammations and preserving the urothelium. But the muscle count is increased in these cases. And they also show the basic background of the severe fibrotic changes in the non-Hanna region diseases. And they reported down-regulation of the Wnt11 signaling pathways in non-Hanna region disease, which leading to the upregulation of the fibrosis-related genes. So, but I think they may have seen the bladder fibrotics, I said, bladder-centric phenotype mostly, because it's BPS it's very, very heterogeneous patient groups. And yes, I received the PhD at the Department of Pathology, and it's my opinion. It's, fibrosis and detrusor histological evaluation, it can be arbitrary and reproducible only when severe. And in the bladder biopsy samples, detrusor muscle is found only in 30% of the specimens. And so muscle count and fibrosis in detrusor muscles may not be properly evaluated in histological assessment of ICBPS. So next, I'm talking about genomics of ICBPS. This is our data of the RNA sequence for the bladder biopsy samples for the Hanna region disease, Hanna region area, and the non-Hanna region area. And the BPS, it's non-Hanna region diseases, and control samples, it's green. So the Hanna region disease and non-Hanna region disease shows a distinct gene expression profiles. And the subsequent biological pathways reveal the specific pathways upregulated in Hanna region diseases, which are mostly involved in the it's aberrant or increased immune responses. Also, recently, we have found clonal expansion of infiltrating lymphocytes in Hanna region disease bladder. And yes, not only B cells, but T cells are also showing the clonal expansion. But B cell clones expand more aggressively than T cell clones. So this is it's a monoclonal expansion, but it is not multiple. And we have also conducted a genome-wide association study for the Hanna region diseases and identified the risk genetic variants in the MHC region. And the fine mapping analysis of HL variants further identifies risk amino acid variants. So this risk variant is also reported as a risk variant of the other systemic autoimmune diseases, such as narcolepsy 1 or diabetes type 1. And these amino acid has a high risk for the Hanna region diseases. And these three amino acids are located at the antigen binding group of the MHC class molecule. So it's my speculations that maybe some patients carrier of these risk variants has altered antigen presentation ability, and which leads to the underlying pathophysiology of HIC. But yes, as I also may have been selecting the autoimmune inflammation-related Hanna region phenotype mostly, because it's Hanna region disease is also the heterogeneous and multifactorial inflammation diseases. So it's a summary from our subcommittee. Hanna region disease is histologically a distinct inflammatory disease. And some of the Hanna region disease may be associated with dysregulated autoimmune responses. That's why the cyclosporin A or tacrolimus or steroid therapy is very, very effective for the Hanna region diseases. And non-Hanna region disease is histologically is not an inflammatory disease. And quantitative analysis of mast cell infiltration and urocellular residue may not be variable in diagnosis of ICBPS. And the functional dysregulation of mast cells accompanied by increased fibrotic changes and alterations of urocilium may be associated with some of ICBPS, especially in non-Hanna region diseases. And Mauro said before, we are preparing the ESIC histopathology score. It's coming soon. So yes, please, maybe in this year. Okay, that's it. Thank you so much.
Yes, I would like to thank Yoshi for this excellent presentation. And I would like to emphasize, if there is a necessity, the role of histopathology. For me, it's clearly absolutely illogical for a complex syndrome like IC-BPS to make a precise evaluation. The oncology, they have the criteria, the TNM, just to classify specifically the problem of oncology. And we, as an expert group, we still continue to evaluate this complex situation with questionnaires, with evaluation of phenotyping, without specific criteria. This is absolutely not an impression of myself or Yoshi or other people, but is specifically. The main problem, you know, which is that there are no so expert pathologists on the world, not only in Italy or in Europe or in USA, but on the world. We have a combination of Maeda, that is a Japanese pathologist, and one pathologist of our group in our university, that they are two experts. And in the new guidelines, our idea is to increase a box in which all the pathologists from outside can have a guide, the really guidelines, to evaluate precisely those type. The criticism could be, but there is no evidence base about biopsy, because no one make the difference. Yoshi clearly demonstrates that there is a line, a route that we need to perceive, and I think this consensus have the starting toward a new approach on this complex situation. Thank you.
Nice presentation. My question is, in the non-Hunter IC, when there is no inflammation, you don't find signs of inflammation, but you find signs of fibrosis, some reports. So do you think inflammation is a moving target? If you don't pick up the biopsy when the inflammation is going up, you pick up in the healing response when the fibrosis was happening. Do you agree with that paradigm, that inflammation is a moving target? You may or may not pick up the classical signs of inflammation if your biopsy timing is wrong.
I think that is very true. With inflammation and fibrosis, kind of the mechanisms aren't fully understood. You can have fibrosis because you have pathological increased laying down of collagen. You can have fibrosis because you have different structures and different tensile strengths on the wall that are reorganizing it. You can have it because you have cells that are coming in and not degrading the collagen that's been built up after an inflammatory event. And all three of those things can be happening at the same time. So I think looking at fibrosis at one time point, inflammation at one time point, really isn't going to give us a good idea of what's going on until we look at over time in the same patient and really understand the progression of what's going on in these patients.
Thank you.
Thank you. I had a question concerning if you're going to make any recommendations as to how a biopsy should be performed. Should it be done before hydrodistension? Should it be done after hydrodistension? Do you need one cold cut biopsy? Do you need multiple cold cut biopsies? If you want detrusor, should we take a resected biopsy? Should you biopsy the ulcer? Should you biopsy not the ulcer? And so I think that if we are going to be looking at something like an Essex score, which I think could actually be extremely helpful, I think we have to have some kind of a systemic way of doing the biopsies in an identical fashion. And I think if you always take your biopsy in the right place, you never confuse a biopsy site with an ulcer.
Yeah, I think that's very true. And the more standardized we can be in how we collect these samples, the more broadly we can compare patients to one another, and the more valuable that the pathology report is going to be to the clinician. So having recommendations for a similar site that's being biopsied, I always think when you're going for biopsies, more is better. Not too many where you're impacting the patient, but you don't want to be relying on just two and then you've been in there and you don't actually get usable tissue that you can assess. And then I also think the question about looking at the detrusor, it's going to be really variable from patient to patient whether or not you're going to get detrusor for evaluation. And especially with cold cut forceps biopsies, I think reliably getting detrusor for evaluation is difficult.
And also, I have investigated differences of the biopsy samples which are taken before the hydrodistension, also taken after hydrodistension when hydrotide. But yes, slightly increased hyperemic changes can be seen after the samples taken after hydrodistension. But no differences in the lymphoplasmacytic infiltration or epithelial deletion can be seen. So the before or after hydrodistension, both can be seen. And I think the multi-sample is recommended because it's a Hanno region. After the biopsies, we are calculating or rejecting most of the Hanno regions. So before taking the Hanno region biopsies, we can take many Hanno region biopsies before hydrodistensions. And also, this is very important. That I recommend taking the one cold cut biopsy sample from outside the Hanno regions and check whether the similar inflammatory changes can be seen in the outside of the Hanno regions.
Interesting, analysis and looking at. I mean, it'd be great if there was something, on a biopsy that says this is IC. I had the same question about before or after because I think it is a lot of mixed in the literature, and if we're going to put some kind of structure to it, we should all agree on it. But just two other questions. Hunter's lesion IC almost exclusively happens on the dome and lateral walls. You almost never see Hunter lesions on the floor of the bladder or at the trigone. So is there anything histological or physiologically different about that area of the bladder that doesn't seem to create Hunner's lesions? And then do we think that the like the fibrosis you might see in non-Hunner's lesions, would it matter? I mean, some people use hydrodistension as a way to treat people, and they're doing it every 6 months. And if somebody's having multiple hydrodistensions, could that lead to underlying fibrosis? Like, does it correlate at all with how much intervention somebody's had on their bladder for the non-Hunner's lesions patient, I guess would be my other question.
I unless you know of others, I don't think we have an answer to the latter of the questions. I think that's something that if we are able to take samples from patients and follow patients over time, we can start to address whether or not these hydrodistensions are having an impact on the bladder and changing it. As far as for locations in the bladder, all of the different regions in the bladder, your bladder is just not a balloon that fills up, as most people in this room know. It has distinct regions to it. It has different micromotions. It has different tethers to the pelvic floor and the pelvic cavity that are going to alter how it's going to move. There's some really great work by Nathan Taikaki, who's done 3D imaging of bladders from mice and looked at the actual micromotions and the way that the bladder contracts and how it moves. And there's distinct patterns to the waves of contraction throughout the bladder, depending on where it is. And I don't think we understand what those motions are doing and what each of the regions is doing in the bladder yet.
And just one last question. In the era of AI coming, because the point came up that not all pathologists are the same or look for the same, it would be great if there was some way to create an AI way that these can be analyzed in a very standardized way that's going to, it doesn't matter who's reading it, letting the computer read it.
Yeah. So. And it's an additional comment about the Hunner region of the dome or posterior and the other regions. It's similar inflammatory changes were seen regardless of the sites of the Hunner regions. But its levels of the HIF1 alpha is upregulated in the posterior or dome Hunner regions. It's maybe suggesting that ischemic changes is increased in the posterior or the dome compared to the neck or trigon.
Hi, great presentation, as always. Rob Molden from New York. Quick question, just a very basic. When I think you have already analyzed, if you could just go over some of the data, some of the inflammatory changes that you actually see in patients who have chronic cystitis or other forms of inflammatory cystitis, whether it be squamous metaplastic changes, even bladder cancers, nephrogenic adenoma, all things that we typically encounter that have that inflammatory component. Do you see differences between the IC Hunner lesion population and those populations? And the second, if you could comment on fibrosis. All of us who do biopsies and see Hunner lesions on a routine basis, including you guys, I mean, you know that there is scarring. You actually see the tethered mucosa, the scarring, part and parcel of the Hunner lesion, irrespective of previous biopsies. Don't get into that whole business, but again, a brand spanking new Hunner lesion. The question I have is, why don't you see more fibrosis in that patient population? And also, do you think could it have something to do with actually where the biopsy is taken, something that Bob Evans just alluded to, a central biopsy versus more of a peripheral biopsy? Are there nuances in terms of biopsies and what we're finding histologically? Long question, sorry about that.
Yes, for the first questions, we have found only the plasma cell infiltration and the clonality of the infiltrating lymphocytes is higher in the Hunner region compared to the other chronic cystitis. But epithelial denudation can be observed in the BCG-related cystitis, and also the B-cell dominant infiltration can be seen in the cystitic cystica or follicular cystitis. Mm-hmm. So it is not, it's very, very specific characteristic to the Hunner region diseases. But the affluent plasma cell infiltration and the increased clonality of the infiltrating lymphocytes maybe is a very, very characteristic feature of the Hanno region disease inflammation. And for the second question, I am not sure. I'm sorry about that. Let's talk to you later. Yeah.
Yeah, I just wanted to make a comment. The question was brought up as to whether the hydrodistension could lead to fibrosis and change in bladder capacity. And we do have a group that we have followed who have been unresponsive to other forms of therapy and requested serial hydrodistensions, and we monitored their capacities, and the vast majority never changed their capacity. So I don't think that procedure in and of itself does anything that cause fibrosis.
Thank you so much. Yeah.
Elise, she has one question?
Yes,
or?
this is for the group, because obviously in our section, we're also worried about whether there could be something infectious. So could we have comments from the group about when you biopsy and send for infectious assessment? And how do you do that, and what are you asking for?
So Steve, do you want to comment on the infectious in the biopsy that we worked on with Loyola Group?
You're just talking about
the infection component. Yes.
Bacteria?
Yeah.
Or like tuberculosis, or, I mean, what else should we be worried about in patients? And I don't know anyone who routinely sends for culture on bladder biopsy, but is there anything we should be thinking about in our section?
We found we sent.
Yeah, Steve, get up and talk about it. We did a work with Loyola, and that's what I wanted to do.
With Alan Wolf. We sent 40 biopsies, 30 from IC patients and 10 from non-IC controls. And in discussing with Alan whether or not we thought we'd find bacteria in the bladder wall, he thought we might find it in a few samples, but not very much. And it turns out in about 90% of the samples, we found evidence of bacteria, live bacteria in the bacterial wall. That was published in J-Urology last year. There was no difference between the IC patients' profile and the controls, but it was a really small number, and Alan's very conservative in the conclusions he makes, so am I. So we could see no differences, but we did 16S sequencing, and there was evidence of bacteria in everyone. The profile in the bacteria in the bladder wall is slightly different. Staph predominant versus lactobacillus predominant in the urine.
Sanjay.
It's in response to Elise's comment there, actually, because this is essentially a global consensus statement that we are preparing. And what the need to biopsy would depend on geography that you're practicing in. So where we practice tuberculosis is a reasonably common. It's not very common, but it's reasonably common enough that we would be looking for tuberculosis in all patients who present with bladder pain and pyuria. And so clearly, the statement of the consensus statement should recognize the fact that you might need to make changes to practice based on geography.
Or schistosomiasis in Egypt.
So precisely, yeah.
Yeah. All right, time for a break. We have lunch downstairs in the room. We had dinner. For those who are not there, it's just one foot below in that corner. They are boxed lunches. The GYN group, I suggest you guys meet up here with your lunch boxes so you can work out your emails. And those of you who want to take a walk, this side of the hotel, Marriott's right across. If you walk out, make a right turn and a half block, there's like a park area if you want to sit outside. Otherwise, welcome. We'll meet back here, start exactly at 1:30.